Frank Talk tonight is with the Minister of Health, Dr. Zweli Mkhize. Let's go straight into the NHI. For the sake of viewers who may not know what on earth we're talking about, summarize briefly, what is NHI meant to be? What is this NHI, and how then is it going to address these issues we're raising about the state of our health?
Let me start by saying what I was just describing are the challenges in the public health sector.
Yeah.
The one issue is that it's funded only through government sources, which is the fiscus. Then there's a private sector, which spends as much money as what we spend on the public sector, but it's only 15%. And the money comes from the funds are contributed by the employer, the employee, and the government incentives, tax incentives. Now, when you have an NHI, you take all of those sources, whatever sources that government used to put in the public sector, whatever the employers, the employees, and the government tax incentives, all of that together, and other sources, you put that together, and you make one fund. Then out of that fund, you've got a body that will then go into a district, and then say the hospitals, the doctors, the nurses, all the health workers there, we will buy these services for you to keep the people in that district healthy. Here are our indicators, and go to every district like that. And therefore, the nature of the system is that it allows everyone to have access to the health system, without having to pay when they get there, because it's already been prepaid, and they don't have to make money, a contribution from their pocket. And in addition, it is the disease complication that determines whether you'll be seen by a nurse or a doctor or a specialist, or whether you go to a tertiary hospital and so on.
Yeah.
Today, what you have is that if you don't have money, you cannot go to get an operation in a tertiary hospital because you can't afford it. And that's what we have to deal with.
Is that the case? I mean, aren't there hospitals that are public hospitals that in fact have better specialists in certain areas of healthcare than even private? Are you saying that people cannot access those for purely from a point of affordability, not just that maybe they may be full or clogged?
This system is open for everybody.
Yes.
Whereas when you're dealing with what you're dealing with right now, you're dealing with a situation where the limitation in the available resources is what will limit how far you can go with the people through the health system.
Yeah.
But what we're then saying is that people who have got access to medical aid can get to the level of care that they need, but because of the nature of the system, sometimes they even get more than they actually need. So you get a headache, then you end up having to go and have an X-ray done or have a scan done, which you don't need. Whereas if a doctor would have looked at you, he would have just given you something and said, no, you don't need it yet.
So essentially, the NHI, and it's coming now to some of the debate that's happening even within the health sector, amongst health professionals and themselves. Is this going to destroy the private health sector to be independent from a public health? In other words, are you creating one health system, not private, not public?
We want a system.
So a person cannot be refused entry into, Park Lane Hospital because they don't have a medical aid, or just because, the costs there are inhibitive. If you simplify it for the public, is it about free health care for all?
Yeah, it's free access.
Without a distinction.
Yeah, it's free healthcare at the point of service. Not that we pay for it as a country, as a nation, but then it cross-subsidizes. So when you pay, it allows for the people who are healthier to contribute, but for the sicker ones to be able to have access to care. We call it social solidarity. So it works in such a way that, once you pool the resources, you've got a way of covering everybody at the same time. So the key thing is you pool as much of those. When you purchase your healthcare, you'll purchase from the public sector, even from some of the private sector. So we want the system to work much closer together than what has been happening before.
What are the implications for medical aids? Right? Will I need a medical aid if we have a system like that? Will I have to contribute to my medical aid if I'm employed somewhere, and at the moment I have, and somebody is contributing to it, the employer is contributing, I'm contributing. Once you say it's free for all, I mean, putting it in a broad colloquial term, why would I still need to contribute?
Yeah, firstly, once we've got the system sorted out,
Yeah.
you will find that the public health sector becomes sufficient for the needs of the majority of people, of all the people. And then there may well be instances where there might be services which will not offer in the national health system. And therefore, those who want to have a medical aid for that can do that, which is separate, which is for themselves. So all in all, we will expect that all the people will be covered without a need for an additional cover, but it allows space for those who want to do it. It will be on top of the contribution.
Meaning that there may be certain services that are only available to those who have a medical aid. I'm trying to find out why you would need a medical aid if the system works well as you are describing.
Well, there are things that I will not give you details now, but there are things that we may not necessarily need to cover on the national health insurance. So just take, for example, some of the cosmetic things that are about beauty and so on, where people want to do it because they need to do it, but it doesn't have an impact on the quality,
their health,
on their life. No. If it's
You just
something,
want to look better.
Yeah, so those kinds of things.
Nice, Botox and stuff.
I will not go into details on that. I'm just giving you that as a simpler example. Yeah. But all in all,
what about private practice? I mean, is this going to affect doctors who now charge an arm and a leg when you go to them, in terms of their consultation fees and so on?
Yes. Those, when it comes to the national health insurance, it does not pay on what we call fee for service. So you come to me, I charge you every time you come here.
Yeah, how does it work?
No, it works on the basis of what we call capitation. So in other words, you say there's a group of 200 doctors in this area, there are 5 hospitals, there are so many nurses and so on. Then they are in groups of practices. There are private practice, there are public institutions. Then you say you have got a population of 2 million people here. For what we need for these people who are going to end up, at an average, so many operations, so many visits to the doctor, so many this, so many vaccinations, etc., to keep them healthy. Yeah. So the budget for that for the year is this. Then we break it down for you every month for this particular practice. That's how much you're going to be paid, and therefore we call it capitation. So you are paid to keep the population healthy. You are not
regardless
paid,
of how many people come to you. Let's say,
no,
as you know now.
That's the point. Because
as you know now, there may be a doctor side by side in a medical center.
Yes.
This doctor, the queue is long. This one, is it's not such a good doctor. People don't like him, and it's only 3 people coming there. Are you saying that now you are leveling the playing field, so to speak?
No,
people are not going to be rewarded according to their competency, time they put in, effort, and so on.
No, the competency we gauge on the basis of an overall agreement of how much of the visits, what vaccination, what preventative measures, and how do we control diseases, and how many operations get done, and so on, based on the need. We don't go on the basis of the patient wants to be seen by a doctor today and tomorrow and the day after, and it's not necessary. So, you see, sometimes we think because we have got medical aid, I can go and see any doctor any number of times a year, and so on. That's why you get what we call over-servicing, where someone will go and see a doctor because they can afford, not because the disease needs it. And then you get to be given, a battery of tests, but you don't need all of those tests. You could have done with just 1 or 2 tests because the doctor knows. But because you think, you also want to be checked on this and that and that becomes what we call over-servicing. That's where most of the wastage and the cost goes onto the private sector, on the private sector.
But
that's the problem.
I suspect then that part of the criticism is that if you've got what you've described at the beginning, right, the kind of crisis in the health sector, whatever the reasons, the overcrowding, the under-servicing of certain elements, etc., in a sense, a sense of poor management, no matter how you look at it, or failure of management, or even failure of systems, right? When you introduce something so complicated that sounds like it's going to require a lot of micromanagement of doctor-patient relations, how many times you go to a doctor, etc. Yes. When we can't at the moment, get a hold of what's happening now, don't you think that there is indeed a concern there that this thing may simply be too difficult to implement.
Well, let me just say
It sounds like micromanagement of healthcare, the way I'm listening to it now, especially on the private doctor access and practice.
No, we don't have to micromanage those doctors. They know what they're doing. We just have an agreement of how they will keep people healthy, and then we have an agreement of how we're going to do the payment. That's all. It's happening like that in Germany, in the UK, in Japan, in many countries. It's happening like that. We are the ones who are behind.
Are we the ones who are behind?
Well, yeah. We are the ones who are behind. But in addition, let me also say that, you see, it is not so much that we have to micromanage. There is a truth, there is a fact that we must acknowledge. When people criticize our health system of being inefficient, public sector, yes. Public sector has also got its own problems, right? When we talk about the facilities not being in good standard, yes, I agree. When we talk about staff shortage, right there, yes, I agree. When we talk about management that needs to be strengthened and upgraded, yes, I agree. So there are real issues that people are raising, which I think we can't even argue about. We must agree, it's true. The fact that there are those do not mean that we must therefore fold our hands and say, well, let's give up. No. The fact is we must acknowledge the wrong, acknowledge the weaknesses, and go and correct them. We will go and correct all of that. And what we're saying is that the fact that there are those weaknesses does not mean we can't institute NHI simply because we must wait until all of this is fixed. What you have said in the department.
All right, just pause there. I want you to for you to pick it up after the break in terms of how do you therefore in a sense phase in what's going to happen, what will come first, and so on, and what is the danger of unevenness at the beginning as you are implementing this, because there are also theory that it may take years, may even take up to 20 years or 15 years before it gets there. So we'll take a break, and after the break we carry on with that conversation with Dr. Zweli Mkhize, the Minister of Health. Stay tuned. Carry on. All right, we're carrying on now with that interview with Dr. Zweli Mkhize. You can follow our show on #YourView on 405. You can also send us some WhatsApps there as we engage on a very, very important matter. I want to go back to what you were saying before the break, right? That what I sensed is that, and please correct me if I'm oversimplifying it, are you going to pay a flat rate to private practitioners? Is that what you are saying? You're saying that you are in this region, you service 10,000 people, theoretically, you're going to share them with a number of practitioners. Therefore, in terms of the budget of this area, you will be paid 10,000 a month. That's it, to do that work. How will it work exactly?
How it works is the size of the practice, the interdisciplinary or multidisciplinary nature of the practice, is the services that are being rendered, and so on. But there will then be a calculation that basically indicates for this particular area, to make people in this, if you divide the whole country up in terms of the nature of services that are needed, there's a calculation that you're going to use. That calculation, therefore, will reward the people in that area on the basis of the total population that they are looking after.
Yes.
Not on the basis that you are going to actually get the patient coming to see you every second day. That is the difference. Now, let's come back to the issue that I'm raising about the weaknesses in our system. We're simply saying that these weaknesses in the system need to be fixed. And to fix them, we use the NHI as the vision to which they must be able to qualify. In other words, you got the hospitals, you got the staff shortage. If you want an NHI to be the system, it therefore needs all of these corrected. So when we start correcting, we're correcting.
So there will be like standards that are NHI standards, if you like. To say this hospital, in order to be considered to meet the standards of the NHI, it must have so many doctors, so many nurses, etc., etc., etc.
In a way, that's what it is.
That's interesting because you've held a couple of pilots over the the last couple of years. One of the things that the opposition was saying in response to your budget vote was that there's not been a report yet of how successful those pilots are. Can you dispute that for me? And if
let me first deal with the opposition, right?
Yeah.
There's the opposition. There are parties who, because of their own views, some of whom are actually more used to defending privileges, debt against NHI, and we will have no time for that. Two, there are those who are already part of the system, the private healthcare, who are worried that this thing might actually reduce opportunities for self-interest. Again, they're fighting. Now, those together are not a big issue. The reality here is that this system has got weaknesses. Pilots or no pilots, you'll find those weaknesses, right? And my point is simple. We will look at the pilots. We will release the report on Friday.
Oh, I see.
Yeah, we will release.
I see.
Now, they jumped the gun.
Oh, I see.
Because they went and they looked at the leaked reports and so on. They jumped the gun. All they want to prove to the public is to say, don't trust this government with NHI. We're saying no weaknesses in the pilot sites will stop NHI. We will correct them. Anything that's a weakness.
Because anyway, that is the purpose of a pilot.
Exactly, is to show what is weakness.
Are you satisfied? Because it says to me, because the sequencing then would otherwise be wrong. I mean, you arrived, you are not even 100 days in office, you have already tabled the NHI bill, right? The debate on NHI has been going on, I think, maybe for 15 years.
For me, the NHI debate has been going on for 29 years inside this country.
Yeah.
All right.
So I'm saying that...
It started 40 years ago.
So am I correct to conclude that whatever the weaknesses may be in the pilots, all they did was to assist you to strengthen,
identify,
in a sense, your resolve to implement NHI and not necessarily to detract you from it?
That's right. For example, there are some things which this report will show. That, for example, some of these integrated school nutrition program, examination, you know, where they screen the children for defects, right? That it works very well, but what is weak, you need to see how to integrate it in a district so that it can be sustainable, you understand? Then in some areas it talks about, you know, you need to have, specialist teams that you need to work on. But you realize that in some areas, some districts, you can't even find the specialists. So you have to change the approach. So if you say there were weaknesses, does it mean that the system won't work? It means you must adjust.
It sounds to me then, therefore, that when this thing is fully implemented, right, it will become a normal way in which healthcare is administered.
Normal. Yes.
It's a new normal, yes.
A new normal.
So why would you need, please explain to me, why do you need now to form a separate fund? It sounds like another parastatal, and I hope it's not, right? Are you saying that the Department of Health, with all its systems and agencies, and I'm sure the Department of Health has a range of agencies, I just don't have the number in my head now, right? Why can't you use the current financial systems within the Department of Health in a sense, to manage the new resources that are now going to be put behind the NHI? Why do you do a separate, in a sense, bureaucracy?
In every country, that's how this works. It works this way. You got a side of the department that deals with issues of policy, okay?
Yes.
And therefore, that continues as one part. The other part is what we call the NHI fund that purchases the services. So those who provide the services are the hospitals, the district health authorities, the nurses, the community health workers, the general family practitioners, and so on, and the specialists, and so on. But as institutions, then the NHI purchases this, the health services from them. That is the way of being able to make the resources to be spread across the whole country. So it operates as two things anyway. And
that can be done by Treasury or the Department of Health. I mean, I'm just worried that it looks like you create another bureaucracy of a huge management thing, a new thing that everybody else must learn and so on, instead of trying to, in a sense, improve the current financial systems, because at the moment, Treasury still has to disburse money to all the provincial governments, right, for health.
Well,
how is that going to now change?
To start off with, you know, in all the countries now, we just 2 weeks ago were in Japan. The Department of Health and Minister of Finance and Health were actually asked to work together. Everywhere, the public sector, the fiscus, the government has to provide the funding to support universal health coverage.
Yeah.
Now, the Department of Health has to create a structure that must manage the fund and then manage the access. Then the other aspect of it has to deal with policy. It operates in that way.
Okay.
Now, the fact that we have had challenges here with state capture, with corruption,
Yeah.
with fraud, does not mean that it is wrong to actually have a system that manages it. It's just that here...
Are you going to build in a sense, things that will ensure, or policies and so that will ensure that there's no runaway train on procurement? I mean, the Premier of Gauteng, you must have heard him when he was swearing in his executive. He made a point of isolating health as an area of big red light where corruption is happening, particularly on procurement of supplies. You know, we've got people calling us here or emailing. I mean, when I was on radio, every other day you will have somebody from a hospital say, oh, what a disaster that's happening here on procurement. People who procure syringes, you know, that would cost 2 rand.
Quite a few things like those.
100 rand.
You see those kinds of things.
Yeah.
That's one thing that we need to always make one straightforward point, and that is, we must stamp that out.
Yes.
And when you've got instances like that, we must stamp that out.
Yeah.
And people must feel free to point out when there are challenges of that nature. That's why I'm saying that we're looking for an app that must be used for people to report when they can't get the medication.
Yeah.
We don't have to wait for the system to tell us. We want, even at some point, people must be able to do that, because you will never stop corruption unless people know that they will know even if their system has not reported to us.
Yeah.
You know, you understand? So it's important that we must deal with it. And people are not, you know, telling stories when they say that they've seen corruption in this and this and this.
Yeah.
There is corruption, and we must fight it and we must stamp it out. And as a start, you can't run NHR on the back of corruption. You will not succeed. You can't run any department at the back of corruption.
Yeah.
So
but that should be scary. I mean, given the scale of corruption. Okay, forget corruption, right? Just financial mismanagement. If you listen to the AG's report on government department,
sure,
and then next time on municipalities, the percent of capacity, or officials with capacity to actually meet the standards that even the AG is setting is so weak. Are you going to have a special intervention? Because this, once you combine these funds, you're talking about a multi-billion fund. You're not talking about a few cents here, right? You're talking about something that's multi-billion, where the track record of management, right, doesn't look so good on government departments, on municipalities, at least according to the AG.
It's not only, that's not the only issue as well.
Yeah.
There's also the issue of inefficiencies where wrong decisions, well, let's say where decisions are taken at a wrong level.
Yeah.
So you have a problem, for example, where someone is actually sitting at head office and is determining what the urology clinic requires in a hospital. That becomes a big problem, because then that's where wastages happen.
Yes.
Now, it's corruption we have to deal with, is correct levels of delegations, is correct competence of this thing. But to underline all the three is consequence management. If there's no consequence management, doesn't matter what you do. And that's the part which we want to make sure it's very strong. And I want us to always to always say, we see, when all these things that is playing itself out in the public about the different forms of corruption and so on and so on and so on, it is something that must empower us to be sensitive, so that we must report it continuously until government is able to stamp it out. Because there isn't a way you're going to run a government government department if there is wastage, if there's malfeasance, if there are irregularities, and there's no action. Then of course we can't get anywhere. Whether it's the same system or it's a new system, whether it's a big bureaucracy or a small bureaucracy, there's a problem. It has to be stamped out, and that one I agree.
I'm glad to hear you say that. One of the things that you raised earlier was the issue of the burden of disease.
Sure.
Right? And after the break, I want us to zone into that. At the recent AIDS conference, a declaration called the eThekwini Declaration was launched, or at the end, it sort of was a culmination of that conference. And it from its reading, even cursory reading of it, it looks like it's raising an alarm about HIV and how we need to change our approach. Now, I want to know what your vision is going to be around how to tackle the HIV scourge. It looks like we're regressing. We've made progress on treatment and so on, but we then in the process abandon issues of prevention or even issues of awareness, because now we've got a new generation of young people who don't know what you're talking about because now they grew up in an era where treatment was seen as cure. And I want us to talk a little bit about that after the break. We're talking to Dr. Zweli Mkhize, the Minister of Health. He's confident that NHI is going to happen. And he's saying to the opposition parties, they must just go away. In fact, it would be interesting to know what your view is, because my understanding is that even within the ANC itself, there was a deadlock on NHI for a long time. So not just opposition parties are resisting.
No.
Let's take a break. After the break, we carry on with that conversation with Dr. Mkhize.